Thank you, Pastor. And thank you, everyone, for waiting to the end to give me this opportunity to share with you. There's a reason that, hang on. There's a reason corporate medicine has been illegal in the United States up until the last 10 years. When a physician has an employer, they're accountable to the boss. And for many years, physicians have always been accountable primarily to the patient, right? It's a sacred relationship. It's a relationship of trust, and it's a covenant. We pledge to you our best medical judgment. When I'm employed, the employer has a significant amount of influence on what I do. An employer can use coercion and financial punishment or reward to change the way I practice. So now that we have moved into corporate medicine, 70% in some areas of physicians are employed by usually a hospital association, which is a corporate entity. A lot has changed in the environment of medicine. The suicide rate among physicians has skyrocketed to about 400 a year. The practice of medicine is just not as enjoyable, I'll say. The rewards have been taken away in many ways. And I'm going to try to explain that to you and explain to you why we need now to try very hard to pass right of conscience laws. We need to raise this issue more and more now because people don't really understand the consequences of what has happened in the transition. So some of the characteristics that we all think of or want to believe in a physician are the trusted, devoted healer, the physician who spends time considering your problem, your illness, and trying to decide how to heal. Physicians, because of their high level of training, using the power of observation, can innovate and come up with thoughtful interventions, and sometimes it changes the course of medicine in history. And again, there's a sacred trust in that relationship between a physician and patient. It's very, very important, and we don't want to lose that. So how did we get from this, in this image that many of us still remember, to this? Most people now, when they see a physician, this is what they're doing. Their relationship is much closer with that computer, and I can tell you most physicians go home and they're spending another 3 hours on the computer trying to finish up charts. It's very frustrating. Even children have transitioned from imitating physicians like this to this. A lot of things have changed. And this is a problem. So I'm going to kind of walk you through some of the things that have happened. Originally, this is the doctor-patient relationship, you and the physician, right? There shouldn't be anybody else in the middle, maybe some supporting staff, and traditionally it's been a nurse or someone else who's been there to help. Okay? When we started getting insurance moving in, it was great for a while as long as the relationship between the payer was with the patient, not the physician. When you shift and make that physician now work for the insurance company in order to justify what he does for you, you've distorted that relationship now, because the physician really does have to work for the insurance company essentially in order to get what you need. Okay, then we got Medicare in the 60s. Okay, that brought the whole federal government in, who promised they were never going to interfere with that relationship. But it just doesn't stay there. It never will. Then we brought in Medicaid, okay? And then you have HIPAA laws, which promise you that your records are private, but actually what happens is it forces the physician to expose your records to about 157 agencies. Whenever you have federal government involved, you're going to have auditors. So auditors are looking at your records, and they're very, very well trained at finding common errors that physicians make for the purpose of fining them. So again, the physicians are now, they have somebody else nipping at them, bothering them, and threatening them if they don't do what they're told, okay? HHS, the head of HHS, depending on who it is, can either have a positive impact on the practice of medicine in the United States or a negative one. Now that physicians are employed by hospitals, the CEO of the hospital and the chief medical officer, who is hired by the hospital to control and enforce compliance by the physicians, have an influence that can be very perverse on the physicians, because the CEO's bottom line is going to be financial. Okay? A physician's not a businessman, technically. It's a professional who's pledged to give their best to you. It's very different than a business relationship. We don't call you clients or customers, you're patients. Okay? And CEOs and CMOs are very good at threatening physicians. They can destroy a physician's livelihood. They can cause them to have their license removed by the state medical board by reporting them. There are a lot of ways that they can threaten a physician and make them comply, because a physician has a lot to lose. They've put at least 20 years of their life into training, and it's a high level of training. It's very rigorous and demanding, and they've sacrificed a lot to get where they are. They're not going to give that up that easily, okay? So now the physician is in a position where sometimes he's weighing the cost of what's going to happen to his patient versus losing everything that he's worked all his life for. EHR is very intrusive. One of the most damaging things, in my view, that has happened in the practice of medicine, because of the time constraint it puts on them. Physicians spend about 2/3 of their time now at the computer. Peer reviews is a mechanism put in place by insurance companies, whereby the insurance company has hired someone to argue with the physician about the care that they've chosen for you. That person's never seen you, never examined you, may or may not be an appropriate referral, for your care, but they're going to make decisions on whether or not you get that care just by not paying for it, by denying payment. When they deny payment, usually that means you're not going to get that care. And then the ACO networks that have now become more prevalent is the corporate practice of medicine. It's the hospital association, the insurance company, and the pharmaceutical working together to control the delivery of care. All of those entities can be lobbied by a drug company or anyone else who wants to sell a product or compete with somebody else. Okay? I can't be lobbied. They can't really pay me to deliver a drug. I would go to jail for that. But an insurance company, hospital CEO, no problem. They can wine and dine them and then make them write protocol for us. Okay? This is not good care. This is why things are starting to look bad, and most people are seeing it. There's about 157 agencies that are getting between you and your physician. Every single one of them is demanding a piece of the money that the federal government sets aside for health care. It doesn't mean that that's actually going to end up getting care to the people that need it. It just is scooped up by the middlemen. And they all create their own need, their own purpose for existence, which really has nothing to do with better care for you. And of course, by that time, the patient's off the chart. I mean, it's very hard to get to the patient when you have to jump over that many entities. It's very hard and very challenging. That's why it's so frustrating. And that's why the whole practice looks more like this, where the physician is on one side. Everybody wants data reported to them for different purposes before he can ever provide the care that you need, which might have taken 2 minutes to make a decision on, but instead it's going to take 20 or more per patient just to get to for you to get the care that you need. It's very intrusive, very complicated, and frustrating for the physician. So some of the problems that you've been experiencing, perhaps, like the balance billing problems, surprise billing in ERs, escalating costs, drug shortages, delays, denial of care, all of that is just a symptom of an underlying problem of corporate medicine. And at some point, there's really not much difference between the corporate practice of medicine and government-controlled medicine. It's still a centralized control, and someone is making a lot of money off of the physician's brain and skill. But they always promise value, and they always promise that all of their little rules and regulations are there for a reason, because they're making sure that your physician is providing quality care. And this is how CMS determines the value of a physician's care in oncology. And as you can see, it's very complex. I'm not sure that that's even how they look at it. I really don't know if they really use that formula, but that's the formula on the record that determines the value of your care. Now, do you see mercy here or compassion? Is there any kind of a trust between the relationship of the physician and the patient? There's not. It's cold numbers, cold formulas, deciding what kind of care you're going to get, what's the value of your life. That's why we need protection for right of conscience, because at some point we're going to be pressured to do things and make decisions that we don't think are right. And it's very hard for us to get around it with all the coercive forces now that have control over us. So when I bring this up with other physicians, the first thing they say is, they can't make me do that. They can't. And I'm saying, why not? You know, how many times in the past month have you made a decision that you didn't like to make because the insurance company told you you needed to do it that way, or because the protocol said this is your first choice of drug? You may not like that choice for your patient, but you did it anyway because you didn't have a choice, really. And if you didn't do it, you were going to get a demerit or a mark in some way that was going to be negative on your record. And as those add up, you become a less quality physician. You're going to look bad on paper. So we're all human beings. Yeah, they can make you do that. So what we need to do is kind of rethink the way we look at a physician. Is a physician a hireling or a professional? When we ask for patient autonomy, does that mean that whatever we want, we get from the physician because we've contracted with them? There's a balance there that we're going to have to try to understand, because the physician should be given some authority based on their education, while not violating your personal autonomy and your rights. It's a balance that needs to be struck, but as the speaker before me was talking about, we really have to be careful how we look at that. When we ask for right of conscience, we're not asking for the right to deny you necessary care. And that comes up a lot. But that's not what we're asking for. Usually the point of highest tension is when we're being asked to end someone's life or do something that we believe will harm a patient. And that's where we need the protection. And it's usually where the coercion begins. It's interesting. Nobody really threatens a physician who's denying someone chemotherapy because their friend got that chemotherapy and they want the same treatment. If a physician usually that says, no, that's not the right treatment for you, is given the freedom to do that. But if a patient has a right for assisted suicide and demands it, that's when they want to force us to provide that service. It always seems to be that the coercion begins when we're forced to do something that ends a life or causes harm. So the Canadian law, when it was passed, I think it gave a lot of encouragement to the thought leaders and the intellectuals in medicine. And they started writing articles. acting as if there was agreement now. Everybody agrees that assisted suicide is a good thing, it's merciful, and it's the thing we should be doing. And so that was in 2015. In New England Journal of Medicine, an article was published titled The Unanimity on Death with Dignity. And the point that was made by that author was that it was inevitable. Not only were we going to all agree that assisted suicide is a good thing, but it's inevitable. It's a change that all of us have to accept. And that once these rights that are granted to a patient become established and accepted, it becomes standard of care. And that's an important point, because when it's standard of care, we're obligated to meet that standard. And that's where the medical boards come in, because they hold us to a standard. And if there's an accusation against us, then we can be brought down for not meeting standard of care. So these are all the states that have assisted suicide laws that are permissive. And in kind of foresight, these are the states that are trying to push back against it and have passed laws that have strengthened the resistance against assisted suicide in different ways. What happens when we are dealing with this right of conscience issue is that we're being told that maybe we shouldn't be doctors if we can't agree to provide these services. And so this was an article in New England Journal of Medicine, and I don't know if you recognize Ezekiel Emanuel, but he was the one who was saying, well, if you don't want to provide abortions, or if you don't want to participate in assisted suicide, then maybe you should be looking at another profession. And I think we need to take that as seriously, because these guys are thought leaders and they have impacted medical care in this country. And they are also influencing the people that are training the next generation of doctors. So by selection, you may see the next few generations of doctors more willing to do these things. So when California passed their assisted suicide law, after a year, there was some reviews to look at the data. And one of the things they found that too many physicians refused to do it. So the author of this one article in Journal of Internal Medicine was saying, well, if a patient is asking for the lethal prescription and there's no physician around to prescribe that who's willing to do it, then that's an injustice. We need to fix that problem. We need to force physicians to do this because the patient has a right to it, and it's wrong. You're not allowing them to have access to the care that they want. And that's the End of Life Options Act. That's what EOLOA. After a year, they had 68 patients that took the lethal dose, and that was out of 79 that were approved, that were given the medication, so only 68 ingested it, and 179 that were approved to take the medicine. It was 96 that were given medicine, 179 who were approved for assisted suicide, but a certain number of those dropped out. But look at the reasons that they wanted the medicine. They didn't want to suffer. It's not that they were suffering. They didn't want to suffer. And they were no longer able to participate in activities that made life enjoyable. So what if I, as a physician, think that that's a really bad reason to prescribe a lethal dose of medicine? Do I have an opportunity to give you my best medical judgment, or am I forced to comply? Because that's standard of care now. And if the medical board is saying that's standard of care, you have to do it, then it's going to be really hard for me to say no. Some of the numbers out of the Netherlands are really interesting, and what I find fascinating is that greater than 50% of doctors that were surveyed, it was 800, they reported that they were pressured by family members to euthanize a patient. Something to think about. So most often we're told, well, we can object. We can object and not actually do the act ourselves, but we will have to refer. That's our responsibility. It's an obligation of the physician, is to make sure the patient gets what they wanted. So the Christian Medical and Dental Society in Canada responded to this, and I think I really like the way they wrote it. But also remember, in Ontario now, the physician is required to participate, and they're fighting that. So they're saying an effective referral to a doctor who will kill is similar to killing the patient yourself. In our view, effective referral and participating in assisted suicide are morally and ethically the same thing. Margaret Dorr is a lawyer that's been very active in the Euthanasia Prevention Coalition, and her statement also is important because she's saying that when we're forced to either participate by writing the lethal prescription or refer to make sure that someone will do it, we're also not allowed to give our best medical judgment to the patient. We don't get the option of saying, well, maybe you should get some counseling first, or maybe you just need better care for your disease and it's not being managed well. Why don't we get you another physician that might be able to treat you and take care of you better? That's not an option we get when the laws say that we must do or refer. The patient doesn't have that opportunity. So a lot of the rhetoric surrounding the assisted suicide laws reassures everyone that there's going to be safeguards and that nobody will be accidentally killed, and that only the ones who really need it are going to be killed. It's really not what happens in the end. Death is never satisfied, is what I say. It's never satisfied. They always push to the next level because there are more people who really are a burden to society. And the way Alex Schadenberg states it is that those safeguards are really just barriers to be overcome. The last and best protection of all patients is a health professional with conscience. We cannot protect our patients if the physicians and the other medical care professionals are not protected. And that's why, in my view, the corporate practice of medicine or single payer is very dangerous, and it changes the culture of medicine for a long time because it changes the generations to come. Their ideology and the way they see people, it's being trained into them. It's very hard to resist. We're all human beings, and when that drum beat is just repeated over and over, and you're going through medical school and it's very intense, and they're telling you that the right thing to do and the merciful thing to do is to end someone's life intentionally, it's going to be hard to resist. And especially as time goes on and you've invested a lot of money and a lot of effort and sacrifice into the practice of medicine, and now you're being told that your license is at risk if you don't do this. So my final point is just that if the physician is free to exercise his right of conscience, it'll be the most effective. It'll be really hard to protect us, even with laws in place, as long as corporate practice of medicine is being exercised. And again, we're all human beings. This is one of my favorite quotes. Alexander Solzhenitsyn said, "To do evil, a human being must first of all believe that what he's doing is good." Thank you.